Our next speaker is Dr. Dipti Itchapporia. She's an interventional cardiologist and the Eric and Sheila Sampson Endowed Chair in Cardiovascular Health. She currently serves as the Director of Disease Management at the Hoag Heart and Vascular Institute, as well as being a clinical professor at UC Irvine. Dr. Itchapporia made history as the 70th president of the American College of Cardiology, becoming the first South Asian American to hold that honor. A leader in cardiovascular health, Dr. Itchapporia is actively involved in clinical trials focused on digital health services that aim to advance health equity and transform healthcare delivery. She has played key roles in national and state initiatives, including the ACC's Health Equity Task Force, the PCRI Advisory Panel, and the California's Cardiovascular Disease Master Plan. She's also contributed to innovation in cardiology through her work with the ACC Innovation Committee and as a board member of the World Heart Federation. Additionally, she serves as an associate editor for JACC. She's received numerous accolades, including the Master of the ACC, as well as being named Cardiologist of the Year. She is a fellow of several prestigious professional societies, and with that, Dr. Itchapporia is widely recognized as a leading voice in the field of cardiology. She's here today to talk to us about cholesterol and how it affects the heart.
Thank you. Thank you so much for that nice introduction. I don't need a big introduction. I'm going to kind of move this because I'm not using this, so it doesn't sort of be a distractor for me. I'm actually not talking about cholesterol, but I'm talking about beyond cholesterol, sort of inflammation and the heart. Do I have a clicker?
Yes. It's on the podium.
No.
It's missing.
Somebody took it. Oh, he did. Exactly. So this is about inflammation in the heart. So I have no disclosures for this talk. So I'm really going to talk to you about what the inflammation hypothesis is, sort of make you think. You've heard a lot about lipids. We all know that if you have cardiovascular disease, you should decrease your lipids. So we know that. That's an established fact. But we also know that there's something more to it. So maybe it's inflammation. Evidence from anti-inflammatory studies, and then sort of talk about future perspectives. A lot of what I'm going to talk about is in this document, Inflammation and Cardiovascular Disease. This is the ACC scientific statement, a report from the American College of Cardiology. A really, really good paper on inflammation that I would really recommend. Very easy to read. A lot of really practical advice in that. So, like I said, if we know that somebody has coronary artery disease, we're very, very comfortable using statins and saying that we need to do aggressive guideline-directed statin therapy so we can drive down that LDL cholesterol. In fact, I'm very aggressive with my patients saying you have to have that LDL less than 55. But in spite of the fact that we do that, what the reality is that even when we get that LDL cholesterol down very low, we still have a significant subset of our populations that continue to have recurrent cardiovascular events. So the question is why? And so we know from the Prove It TIMI 22 that in spite of intensive statin therapy, that there was residual risk that happened. Now, the initial study was with pravastatin, where we saw an event rate that continued at 26%. But even when you did atorvastatin 80 milligrams, there was an event rate of 22%. So why? That was the issue. That was the bad news, is that we continue to have that risk. So if you look at the collaborative analysis of 31,000 statin-treated patients across the PROMINENT trial, the REDUCE-IT trial, the STRENGTH clinical trials, and it showed that the critical hidden driver was this residual inflammatory risk. So something in addition to lipids. And so again, if you look at this, the round boxes in this particular slide, what you see in blue is the residual inflammatory risk. So in the Prove It trial, in spite of high intensity statin, you had almost 29% that had a residual inflammatory risk. If you then added not only high intensity statins, but you added ezetimibe, which is certainly something we can think about, we still saw that there was a large number in that blue box in that Improve It trial that still had a residual inflammatory risk. Now, what if we added a PCSK9 to all of that? Let's say we added, so we have the high-intensity statin plus a PCSK9. Again, look at that blue box. We still have a residual inflammatory risk in all of these patients. And how do we know they have this residual inflammatory risk? Because their high-sensitivity CRP was greater than 2. That's how we did it. So then the thought was that these patients need to be targeted also. And the question is how. So this is where inflammation has really emerged as a risk factor. So we know about the traditional risk factors, right? Smoking, diabetes, hypertension, age, which we can't do anything about, genetic predisposition, but this inflammation is becoming the big thing that we're talking about. So we know that inflammation actually outperforms cholesterol in predicting recurrent events. So the clinical reality is amongst patients that were aggressively managed, as I mentioned, those with high sensitivity CRP greater than 2 still experience remarkably high recurrent events. So if you look at all the different quartiles of LDL these are patients that were statin treated, they had really high LDL cholesterols, you can see what the hazard ratio is. But if you look at high sensitivity CRP, for each increase in the quartile in the high sensitivity CRP, the risk increases. So there's this paradigm shift that we have. Atherosclerosis is no longer viewed solely as a lipid disorder, but it's fundamentally a lipid inflammatory disorder. And that's what I want you to take away from this talk, is the thought of this inflammation. So LDL cholesterol is not enough for risk stratification anymore. So again, the same information on the previous slide, but I want you to look at the fact that if you had somebody with low cholesterol and low inflammation, look at what their hazard ratio is. But if they have high cholesterol but low inflammation, they were at the same risk as somebody that had. So if you had low inflammation, didn't matter what your cholesterol was almost. Now look at the group where it has low cholesterol and high inflammation, they were at high risk. If they have high cholesterol and high inflammation, they were at high risk. So inflammation seems to be the driver that decides what that risk is. So there are limits of LDL control. That's the bottom line. And what we know is up to 60% of secondary prevention patients harbor a hidden residual inflammatory risk despite aggressive contemporary care. So that's what you have to look for. Look for those patients that have an LDL cholesterol. And these were older studies, so that's why it says less than 70. But even if you take 55, identify those other inflammatory risk patients by checking their high sensitivity CRP. Last year at ESC, they introduced this new clinical syndrome called Smurfless but inflamed. So Smurf is your standard modifiable risk factors. If somebody is Smurfless, they have no standard modifiable risk factor. And what you're really interested in is those patients that are Smurfless but inflamed. So patients that may not, so you have patients that come to see you all the time, and they say, well, I want to get my heart checked out. So what do? We say, do you have hypertension? Do you have diabetes? Look at age, look at genetics. We do the standard stuff. So they may be Smurfless, but are they also inflamed? That's what you have to look for. So you have to look at those Smurfless but inflamed patients that have the elevated high sensitivity. So we have to think about those Smurfless but inflamed. That's the unmet need. Those are the patients we're missing. Now, we are good about the classic lipid risk. That combined high risk, we don't necessarily identify as much, but we definitely need to get that box that's Smurfless but inflamed because we need to get to those patients. And so whenever you look at a patient, not only look at their LDL, but look at what their high sensitivity CRP is, and think about not only their residual cholesterol risk, but think about their residual inflammatory risk. And so going back, what I told you was that it was an active immunoinflammatory disease. What does that mean? What is the biology behind this? Well, step one, you have these lipoprotein entry and oxidation, right? So you have ApoB containing lipoproteins that enter the subendothelial space and undergo oxidative modifications, so the oxidized LDL, as we call it. This then leads to endothelial dysfunction. And this is where the modified lipids will trigger a release of some cytokines activating the endothelial cells and upregulate the adhesion molecules, the VCAM1 as they call it. And then the next step is that we have this innate immune activation. Monocytes will infiltrate the intima. They differentiate into macrophages and absorb that surplus lipids to form the foam cells. And we all know the foam cells are the early step in developing atherosclerosis. And then this all leads to plaque instability. This is where you have chronic local inflammation that leads to the necrosis, the matrix degradation, and a highly prothrombotic state. That's really the engine. This is the biologic explanation for atherosclerosis. And then there's this issue of clonal hematopoiesis. And this is a para-inflammation. This tends to be chronic low-grade tissue stress that occurs predominantly in older people, right? About 10% of those over the age of 70 have what they call CH or chip factor. And actually the American Heart Association did a statement this past year on what CH is. And the reason that they did this statement is because this is about low-grade inflammation. We all know that one of the risk factors for coronary artery disease is aging. But why is that? It may be because of this, in part because of CH and the chronic inflammation. And when you have CH, you're more likely to have the cytokine and the inflammatory cascade that leads to atherosclerosis. And so we know systemic inflammation plays a critical role in the development and progression of atherosclerotic cardiovascular disease. And when you think about inflammation, you need to hear this word inflammation. So this is NLRP3 inflammation. That is what is activated and causes the inflammatory cytokine cascade. And the cytokines that are cascaded are IL-1 and IL-6. These are the upstream regulators, and they can be pharmacologically targeted. I'm going to be talking about that in this talk. And then CRP is the downstream biomarker of this inflammatory response, indicating that more than 2 is that increased risk. So this NLRP3 inflammation, this is what senses that cellular danger, right? So when you have modified LDL, oxidized LDL, you have these cholesterol crystals that are sitting there, the inflammation gets activated, and then that is where the cascade occurs, where you cleave that IL-1 beta and get to IL-1, and then IL-6, and then CRP production. So this is where the whole inflammatory axis occurs, and you have that hepatic production of CRP. And so this is that inflammatory axis in the atherothrombosis that we think about. And so CRP then is the powerful determinant of cardiovascular death, regardless of LDL, as I mentioned. Again, another study with 31,000 patients, statin-treated secondary prevention trial that showed that if your CRP is high, your cardiovascular death risk is higher. And that's not just in primary prevention, as the last slide showed, but also in secondary prevention, patients post-PCI. So just keep that in mind. This is a large study out of Stockholm between 2007 and 2021. Again, 35,000, almost 36,000 women in there, almost 49,000 men. And they found that 6 out of 10 of these ASCVD patients had a high sensitivity CRP of greater than 2. So that's a huge number. So that is something, if we're not looking at it, we're missing those patients. And so what do we look at? Well, when we look at high sensitivity CRP, obviously less than 1 is low risk, 1 to 3 is average risk. Well, I would say greater than 2 is really a higher risk. Here in this slide, it says greater than 3, but really I would say anything over 2. And in the UK Biobank study of almost 450,000 patients, the high sensitivity of CRP greater than 3 was associated with a 34% higher MACE risk and 61% higher cardiovascular death risk compared to if it was less than 1. So, and then remember, high sensitivity CRP is really stable over a period of time. And so, it is comparable to things like LDL and blood pressure. So this is something to think about. So in 2025, when they published that statement that I mentioned at the beginning of the talk, the mandate in that talk was that ACC now recommends universal screening of high sensitivity CRP in both primary and secondary prevention of these patients. So the consensus recommendation, this is exactly from the document. It says, because clinicians will not treat what they do not measure, universal screening of high sensitivity CRP in both primary and secondary CVD prevention represents a major clinical opportunity and is therefore recommended. Whereas several other biomarkers such as IL-6, fibrinogen, neutrophil to lymphocyte ratio can also predict risk, Routine evaluation of these adds little to high sensitivity CRP. So you don't need to get an IL-6. You don't need to spend the money for all those extra assays. So again, one of the reasons I put this slide on was when you do high sensitivity CRP, sometimes you'll see, sometimes they'll come back greater than 10 or really high number. What do you do with that? Well, that's usually an acute phase reactant, right? And so that could be elevated if somebody has an infection. And typically in a situation like that, you look for an infection, but you can repeat that because that, those lower, that's not as helpful when it's that high because I think there are other things, other factors that may muddy the waters in that. So when you look at the broader landscape, when you look at that high sensitivity CRP, this was interesting. To me, a 30-year follow-up study of almost 28,000 women demonstrated that a single random assessment of high sensitivity CRP provided a greater spread of long-term risk than LDL or lipoprotein A. So again, this is something so hope you're getting the message that high sensitivity CRP is something you need to do. Now, is there any other way we can measure inflammation? There's a lot of work being done in this area. So ultrasound, there are lots of novel imaging techniques that are trying to look for vulnerable plaque before rupture, right? So CT-derived perivascular fat phenotyping probably has the highest near-term promise for predicting those future cardiovascular events, independent of calcium scores, by the way. But they're looking at it for ultrasound, and I can tell you in the digital world, in the AI world, this is a race for trying to find relevance because all of these imaging technologies are looking for a way, can we see things with radiomix, which is what we can't see, but AI may be able to pick up to say, can we somehow predict these patients that have this vulnerable plaque? And so the perivascular fat attenuation index is one that you hear about in CT because there's some growing use of that in practice. Cardiac MRI they're trying to look for that, really not currently available. And then again, PET CT MRI, we don't really have the clinical expertise in general practice to utilize that. But I do think CT with the perivascular fat attenuation index may be a way from an imaging modality for us to know about inflammation. So now it's time to turn. We've established that inflammation is a problem. So the question is, how do we treat it? How do we target it? So when you, again, remember it's cholesterol, hemodynamic flow, hypoxia, all of that, you get the NLRP3 inflammasome gets activated, and the first target then is right with that activation. And so there are different mechanisms in different places. So if you look at the microtubule polymerization inhibitor that will affect this NLRP3 inflammasome, that is colchicine, which is a microtubular polymerization inhibitor. And so that's the first target that we're going to talk about. So in the colchicine era, the low-dose colchicine, 0.5 milligrams daily, is the first FDA-approved anti-inflammatory agent specifically for ASCVD secondary prevention. Intended as an adjunct to lipid-lowering therapies, it may mitigate some residual inflammatory risk in these chronic stable disease. Now, the studies have shown there's been the COLCAT trial, there's the LODOC 2 trial. All of those trials have shown almost a 25% reduction in cardiovascular events in patients that have this residual inflammatory risk. Now, what about an acute ischemia? So this is a caveat. The timing of taming of inflammation is critical, right? The Clear Synergy trial that came out showed no primary endpoint reduction when colchicine was initiated during an acute STEMI. So this is why I put it as secondary prevention, because we don't really have the data for primary prevention in this. And so, and then of course, just a caveat, remember a significant liver disease and renal disease, you can't really use colchicine. But the 0.5 milligrams is approved for the secondary prevention. And so, but I would say the bottom line with them is updated meta-analysis inclusive of our trial confirm an overall 25% MACE. So remember, timing is critical in these patients for that. So I mentioned that it was approved in 2023, colchicine. And so I'm curious, because this has been around now for 3 years, right? Can I see a show of hands? How many of you routinely check this and use colchicine in your chronic stable patients or as secondary prevention? Okay, Rich, you don't count. I do use colchicine, and it's actually quite well tolerated. So just it's interesting that with all of that data out there, so. And the anti-inflammatory therapy has entered all major guidelines in America and Europe. So these have been incorporated in the American guidelines starting as early as 2023, and then in 2025, there's recommendations in the acute coronary syndrome guidelines to utilize colchicine. So what about the next target? The next target, if you go, is IL-1, because we talked about IL-1. And so interleukin-1 inhibitor is canakinumab. And so that was the next drug that was looked at in the CANTOS trial, which was in 2017. And the CANTOS trial reduced MACE, proved that IL-1 acts as a causal pathway in this atherothrombosis, and actually did well. But there was really high cost, subcutaneous dosing every 3 months, and modest absolute benefit, and absolutely no benefit in all-cause mortality, and a slight increase in their infection risk. So this really didn't take off, in spite of the fact that there was a lot of buzz when this data first came out, that, wow, we're going to be using IL-1 inhibitor therapy, but we're not. But I'll come back to that because there is something that's come out of that. And so, and that is, and then of course, low dose methotrexate. You know, our rheumatology colleagues use methotrexate and they use it for inflammation. Why can't we use it? So they've tried it for broad general immune suppression, and there was no clinical benefit, in spite of the fact that we all were so excited about the fact that maybe we could use something like methotrexate. It didn't really make any difference in terms of downstream IL-6 or high sensitivity CRP. So the lesson here is not all anti-inflammatories are equal. So general immune suppression is ineffective for cardiovascular risk, and we need to do more specific targeting of this atherothrombotic inflammatory axis. And so let's go back to our map. We said colchicine works, IL-1 not so much. How about going downstream? How about IL-6? And so there is an IL-6 inhibitor, which is zituvimab, and that is being studied right now in several trials: the Zeus trial, the Hermes trial, and the Artemis trial. And these are in the Zeus trial. It's being utilized in individuals with a history of atherosclerosis, chronic kidney disease, and residual inflammatory risk. And then if you take a group of patients with heart failure and preserved ejection fraction, that's the Hermes trial. And you notice these trials, these are 6,200 patients in the Zeus trial, 5,600 patients in the Hermes trial. And the Artemis trial, which I'm excited about, is 10,000 participants. And these are patients that have had a myocardial infarction. And I think the data is going to probably come out either at the end of this year or early next year for the Artemis trial. And so this is going to give us the final answer for the IL-6. But I will tell you, the phase 2 trial, which was the rescue trial, saw this huge waterfall reduction in high sensitivity CRP, almost down to 92% in some of the early trial results. And so, this is really near double the biologic effect that we saw in the CANTOS trial. So we saw a huge reduction. And the question is, is that really going to pan out into all of the deliverables that we need? Is it going to decrease mortality? Is it going to decrease MACE? All of that. So we're going to have to wait for all of those results. So this is the pipeline at the interface right now, the target IL-6 inhibitors that we talked about. There's also the NLRP3 inhibitors, and the VTX3232 was just, they had an abstract on that at ACC in New Orleans in March, and that is a once-a-day inhibitor, and it actually is showing some benefit in decreasing some systemic and liver inflammation in patients that were obese alone or in combination with semaglutide. So we'll have to, again, wait for this data as it comes out. But there are lots of things in the pipeline specifically looking to target this inflammation. So these are some of the IL-6 blockers that are being tested right now. I don't have all the data on that, but there's certainly, and they're using it in all kinds of things, Crohn's disease, rheumatologic disease, that they're saying, okay, could there be a benefit in terms of cardiovascular? And then these are the NLRP3 inhibitors and then I mentioned the VTX3232 earlier. So those are all the things. Now, what about lifestyle? It sounds great to say, let's do all these drugs, but gosh, people are tired of taking all these drugs, right? Please don't break my back with one more drug. So what can they do? Well, diet. So Mediterranean DASH diet. We know that high intake of omega-3s with the EPA, DHA can promote specialized pro-resolving lipid mediators, right, that can actively decrease inflammation. And then particularly limiting your refined carbohydrates will decrease your inflammatory response. How many times have you heard a patient say, I cut the sugar out and I feel a lot better, I don't ache as much? You hear it, right? Because we know that carbs can lead to the inflammation. Exercise is another biggie. What we recommend, greater than 100 minutes, 150 minutes per week of moderate or 75 minutes per week of intense physical activity will decrease that pro-inflammatory cytokine levels. We know that. Weight management, we know that patients that are overweight will have more inflammatory responses. And so we need to say weight management. And now, especially now with the GLP-1s and the indication, I think it's really hard to say if you have a patient that's overweight, we can, at least now we have some tools that we can help them with given the cardiovascular data that we have. And then smoking cessation, we know that this decreases that chronic low-grade vascular inflammation. And so you have to bend the curve through behavioral intervention, right? And so I think that we know dietary modification, aerobic exercise, smoking cessation. You have to push this in all of the patients that you see, because I think you can't have this discussion without having the lifestyle discussion and behavioral modification for these patients. And so what about going beyond? We've talked about coronary artery disease, but what about, I mentioned to you that at least in the IL-6 inhibitors, they're looking at heart failure, but heart failure has a lot of inflammation. There's a lot of chronic low-grade parainflammation that can predict morbidity in these patients. And elevated IL-6 really portends poor outcomes in these patients with preserved EF. That's why we're seeing the IL-6 inhibitor, particularly looking for these HFpEF patients. So there's some data that will come out for that, but also in patients with pericarditis. So this is where targeted IL-1 blockade showed a huge decrease in benefit in these patients with recurrent pericarditis, and now we have a drug that actually can help with that. So these are the things. So this is our arsenal that we have of anti-inflammatory arsenal, right? Certainly statins do bring down some of the inflammatory response. Colchicine, as I mentioned to you, with the NLRP3 inflammasome inhibition. And then omega-3s will have some decrease. And then, of course, the IL-1 blocker particularly for recurrent pericarditis. So these are drugs that we have right now. But, it's becoming quite a competitive landscape because semaglutide and tirzepatide, both drugs have significant weight loss, but also reduce the high sensitivity CRP and IL-6 use. And the outcome data are available with both semaglutide and tirzepatide. And of course, weight loss is popular. So if you give them that, they have an anti-inflammatory. In the last week, I saw 3 patients that all were doing microdosing, and they all said that for whatever reason, one had to come off because they were having a colonoscopy, another one because she ran out of her drug, and they all said to me, Doc, I felt so much better, I didn't ache as much. And so, the patients all want to stay on these drugs because of these other benefits. Not everybody feels it, but certainly I happened to see 3 last week that said that to me. And this is the data from CRP reduction with semaglutide. This was in the Pioneer 2 trial. You actually saw that reduction and then the STEP heart failure trial. So you saw the CRP comes down. So there is clearly some anti-inflammatory effect. So when we put it all together, what's our optimal cardiovascular risk reduction? Well, it's lipid lowering for sure. So the old paradigm that plaque buildup is driven purely by cholesterol accumulation, no, that's not true. We need to think about the second pillar, which is inflammation inhibition, looking at that high sensitivity CRP, because that's the new reality, that plaque is this lipid inflammatory disorder, and that we need to think about that. And the evidence linking inflammation with atherosclerotic cardiovascular disease is no longer exploratory, but it's compelling and clinically actionable. The time to take action has now arrived. That's a statement right out of the statement that I mentioned to you. And so what should clinicians need to know? Well, targeting inflammation is a proven strategy to reduce cardiovascular risk independent of lowering cholesterol. Routinely measure inflammation using high sensitivity CRP in primary and secondary prevention. And then we should, if we continue to see elevated high sensitivity CRP, we should not only think about statin intensification, regardless of the level of LDL, but also think about maybe one of these new drugs that's coming out. So the scientific statement, this is what they're saying, is the universal screening is a high sensitivity CRP. And then if the patients have elevated high sensitivity CRP, then as I said, increase the statin therapy, And then if it still stays high, then consider these patients for low-dose colchicine in the secondary prevention pathway. So this is my view. I put this slide together based on the reading and said, what is the holistic anti-inflammatory algorithm? So yes, do the universal screening, high sensitivity CRP alongside with the LDL in all at-risk populations. And then even the ones that sometimes come in because they have family history and you can't find an identifiable one, remember those are smurfless but inflamed. And then take action if their high sensitivity CRP is greater than 2. Make sure the foundation is there for all the patients, which is the Mediterranean diet, the omega-3s, the aerobic exercise, smoking cessation. And then in terms of primary prevention, intensify their statins. Secondary prevention, add colchicine. And if they have recurrent pericarditis, then obviously think about the IL-1 blockade. So your conclusion, the key takeaways, clinical guidelines reflect the shift in our understanding and the growing evidence of inflammation on atherosclerosis, cardiovascular disease. Inflammation is measured with the high sensitivity CRP and is a modifiable risk factor in cardiovascular disease and should be assessed in all patients so that inflammatory status and the upcoming and ongoing clinical trials of IL-6 and those targeting Lp(a), which I didn't talk about in this, may further unravel this potential for targeting inflammation and cardiovascular disease. So I am going to stop here, and I'd be happy to take any questions. Thank you.
For secondary prevention with colchicine, do they have to have a symptomatic event, or can it just be any type of documented cardiovascular atherosclerosis? Or do they have to have had an event?
No, they don't have to have an event. Yeah.
Can you speak a bit more on a couple questions? One, when we talk about high sensitivity CRP, I know you said all at-risk populations, right? So like we know, for example, like South
Right.
Asians, they tend to have higher populations. Native American patients, they tend to have higher propensity in their populations. And so are we looking at like any age group, or at like what age are you, number one, assessing the high sensitivity CRP? And then the secondary question in regard to the colchicine, what about our patients that are not supposed to or not able to be on NSAIDs? Can you speak a little bit on like patients with bariatric surgery, patients with previous history of gastric ulcers, melanoma, hematopoiesia, whatever.
That's a load.
Maybe on, maybe on colchicine as well.
So going back to your first question about the age, it's hard to say that there's an age cutoff because then the bigger question you're asking is what age do you start screening people for cardiovascular disease? So I think, again, it goes back to, certainly patients that have strong family history, maybe you start them earlier to start screening those patients. But, I happen to think we need to be looking at patients more upstream anyway. So the earlier, the better. Do I have an age cutoff that you say, oh, you only check the high sensitivity CRP? No, because that's like saying you only screen for cardiovascular disease at a certain age cutoff. I don't think that's true because what happens with atherosclerosis, it's a disease that occurs early. That's why they're saying to check lipids in your 20s, right? So maybe maybe that's when we're checking it early because maybe you modify those risk factors earlier. If somebody's obese, their dietary habits, do we want to wait to modify that when they're 50 and 60? No, maybe we want to modify that when they're in their 20s anyway. So that, as far as the colchicine utilization for somebody that can't take non-steroidals, I don't see that that's really a big issue. I mean, I think colchicine in general does have GI side effects. The 0.5 seems to be pretty well tolerated because it's once a day, not twice a day. I mean, the colchicine that we tend to have a lot of GI issues is 0.6 twice a day rather than the 0.5 once a day. So, and then I think you had a lot of add-ons to your question. It's hard to I'm not sure exactly what you were asking with that. But maybe we can talk offline because I'm not sure exactly what you were asking about that.
No problem. Can I just, I guess, a tertiary question? Obviously, when you ask, like, who in this room, besides the speakers, right, uses colchicine, all of our hands were down. And so I think this is a big education point where we can learn these lessons. And so could you maybe speak a little bit on like, what you would consider a very fantastic patient who comes in who would be a great candidate?
Yeah, so somebody that has vascular disease, somebody that's had a myocardial infarction that comes in to see you, you've maximized their lipid therapy, and now you just check to see if they still have an inflammatory response. So if their high sensitivity CRP is still elevated, I would consider low dose colchicine on those patients.
How often do you check high sensitivity CRP? Is it annually? If it's
It depends on, yeah, I would think it depends on what you're doing. If they've been stable on it, then maybe once a year. But if something is changing or you're changing medications, then you may check it a little bit more often.
Well, we don't have coronary artery screening with CTAs, so high sensitivity C-reactive protein, easy enough to test.
Right.
All right,
We have one
thank
more
you.
question.
Yep.
Yeah, for a young athlete with high sensitive CRP, also has a family history of MI, can that young athlete now be put on treatment based on the inflammatory response being high?
If it's just that, so if their high sensitivity CRP is high, and you're asking whether you can do colchicine on those patients?
Yes.
Well, I think you would want to know that you've treated them with lipid lowering. I guess I would want more information on that patient. I would certainly think about it. It's not probably the first thing I would reach for, but it's certainly something I would think about.
No, the patient has a very, cholesterol is very perfect, but
It's perfect.
yeah.
It's hard to believe that.
Actually, it is, yeah.
Then I would check their lipoprotein A. I mean, I still think, and when you say perfect, what is their LDL? Then maybe a calcium score. I mean, I think you need more information on that patient.
Okay.
With that, though, would we ever just test the oxidized LDL?
No, I don't usually, I mean, I don't know. Rich, do you check oxidized LDL a lot? No, I don't. I don't check that.
I was wondering if there is any role of TNF, anti-inflammatory, in this kind of situation.
TNF, anti-inflammatory?
Yeah, tissue necrosis factor.
Not that I'm aware of, yeah.
All right, thank you. Thank you for flying in. And